The health insurance industry has commissioned a variety of reports that reference a cost shift to private health plans from Medicare and Medicaid. I notice that nowhere do they ever suggest that perhaps the private plans are paying too much rather than Medicare paying too little, but that's, I can understand why they wouldn't want to raise that issue. Last week we heard the argument from an actuary whose report was paid for by AHIP and Blue Cross, and you mentioned this so-called cost shift in your March report. Can you explain MedPAC's view of this argument and whether it's supported by your research? And when others do this analysis, are they analyzing what is the right price for Medicare?
Our concern, Mr. Chairman, is that overly generous private payments drive up costs, and that flows through and affects the Medicare system. We see evidence of that in two types of data. If you look over time at the relationship between hospital margins from private payers and Medicare costs, if you look at that as a time series looking back a couple decades, you see that eras where the payment from private plans are high, that has a negative effect on Medicare margins. Medicare margins turn out to be low. The other look at it that we did was to look among existing hospitals and look at those that are under financial pressure and those that are not. And by being under financial pressure, we mean institutions that don't have the luxury of having generous payment from private insurers, who feel a lot of pressure to control costs. Their costs are significantly lower than institutions who have generous private insurance payment to support their operations. It's about a 10 or 11% difference. So the ones under financial pressure are able, in fact, to control their costs and reduce their costs when they need to. Of course, the next logical question to ask is that lower level of cost consistent with providing a high quality of care to Medicare beneficiaries? So what we did was look at hospitals and identify a group of efficient hospitals that have both low costs and high quality scores on issues like mortality and readmissions. And we found that, in fact, there are institutions that are able to combine low cost with high quality. Our statutory charge, the assignment that the Congress has given to the Commission, is to identify payment rates for the Medicare program that are consistent with the efficient delivery of health care services. So looking at all these different types of evidence, we conclude that the problem is not that Medicare rates are too low, and we think that they are consistent with the efficient delivery of services. One last point on the cost shifting issue. In order to be able to shift costs, to increase charges to private insurers, a hospital would need to have market power. Would need to have some leverage to say, oh, we're not getting enough from Medicare, we're going to charge you more. So if an institution has that sort of market power, it raises the question of, well, what if Medicare increased its rates? Would they automatically reduce their rates for private insurers? If they have substantial market power, sufficient market power to shift costs, as is alleged, it's not at all clear to me that higher Medicare rates would result in lower rates to private insurers. For-profit hospitals will seek to maximize their profits. Not-for-profit hospitals will seek to maximize their revenue so they can do good things with it. So higher Medicare rates, it's not at all clear to me that that leads to lower private insurance rates.
In your first chapter of the March report, you pointed out that while public and private programs have both seen rapid growth in spending, Medicare spending per enrollee has historically grown more slowly than the private insurers' spending per enrollee. What accounts for Medicare's better cost containment or slowing of its rate of spending growth? And do you think that some of Medicare's innovations, such as prospective payment, have contributed to this? And can we solve the problem of rising healthcare costs by looking at Medicare in isolation, or do we have to combine the whole thing, look at Medicare and the private plans?
Well, if you're referring to a graph that's in our report, as I recall, looks at the rate of increase in Medicare costs compared to private insurance costs going back for 30 or 40 years. If you study that graph, what you see is that in particular, since the 1980s, the Medicare rate of growth has tended to be lower than the rate of growth in insurance costs in the private system. Of course, the significance of the 1980s was the advent of the prospective payment system for hospitals, and then ensued from that a series of other changes as well, prospective payment systems and the like. The one exception to that general trend is in the mid-1990s, when, in fact, the growth in private insurance costs were lower than Medicare's. And you'll recall, of course, that was the period of managed care and active management of health costs by private insurers. But if you look at the whole picture, on average, as you say, Mr. Chairman, the Medicare rate of increase is somewhat lower. Now, there is some disagreement. You can find experts on both sides, some saying, well, it's really not an apples-to-apples comparison because of differences in the benefit structure. And then others say, well, even if you account for that, it's still true. And I'm not sufficiently expert on the technical things to judge those two. But the data do show a lower rate of increase in Medicare.
Thank you.